My name is Stephanie. I'll be doing my healthy person presentation on heart disease and stroke. So the reason that this is such a problem for our community is that heart disease is the #1 killer when we look at disease processes, and stroke is the 5th leading killer. It's vital to raise awareness to these diseases because the more that you know about them, the more that they can be prevented. They are preventable for many people. Many of the risk factors are modifiable. So when we talk about cardiovascular disease, it's an umbrella term. And commonly, cardiovascular disease refers to coronary artery disease. That is the disease of the heart muscle itself. It becomes occluded, it can lead to an MI or a heart attack. And you can see this when you look at labs. You'll see elevated troponins, which is the protein that's emitted by the heart when it is under stress, when it is lacking oxygen and becoming hypoxic. And you can also see it on EKG or telemetry. You can have an ST elevation, and it's called a STEMI. So some signs, symptoms, and risk factors of heart disease: high cholesterol, diets high in sodium and fat, and sedentary lifestyle, obesity, smoking. These can lead to hyperlipidemia, high levels of fat in the blood. This is a sticky substance. It can form a thrombus or a clot, and it can occlude your vessels. Cardiac dysrhythmias are also a risk factor. A person who's in atrial fibrillation, the atria of the heart, the top chambers, are quivering. Blood is never fully perfused, so it's sitting there stagnant, and stagnant blood clots. So they're at a higher risk of a clot dislodging. They'll typically be on prophylactic anticoagulants such as warfarin or heparin, and one nursing consideration with those is that they're also at an increased risk of bleeding. IV sites can bleed, they'll bruise easier, and if they fall, they are at a higher risk of sustaining blood loss. And as I said, with the thought of a clot dislodging, heart disease and stroke. Blood pressure, the constantly increased pressure on the walls of the heart and vessels, it leads to hardening of the arteries. They're not able to fully contract or dilate, and that reduces perfusion and venous return. Some common medications for the cardiac patient are beta blockers. These block the effects of epinephrine, sometimes called adrenaline, which, it's that fight or flight kind of chemical. So if that's blocked, then it's going to relax your heart, it's going to calm it, it's not going to be so reactive. These medications end in OLOL, like metoprolol. These are typically a slow push when they're given by IV because they work drastically and instantly, and sometimes you don't even need to give the full dose to get the effect that you're looking for. And typically, these medications, when given orally, are given synergistically with a diuretic like furosemide or Lasix. Another common cardiac medication is the ACE inhibitor. These ACE inhibitors inhibit the conversion of angiotensin 1 to angiotensin 2, and angiotensin 2 is responsible for narrowing the vessels. So if we can inhibit that conversion, then we're going to leave your vessels open, and we're going to allow more blood to flow through with less resistance. These medications end in pril, like lisinopril. A consideration when giving all of these cardiac medications is your pulse rate and your BP. So the effect that you're going to see is you're going to see your pulse rate drop and also your blood pressure drop. Typically there are parameters set with these medications to hold if the heart rate is less than 60 and the blood pressure is less than 90/60. Really follow your orders, but use your judgment. If you feel like a person is already exhibiting signs of like hypotension, for instance, you can hold that medication, consult the physician, and see the best course of action for that patient. Also, with the ACE inhibitors, an important fact is that the bradykinin is building up, and that causes a very irritating cough. For some of these patients, that's enough of a reason to discontinue use of this medication and seek another medicine. We also have the calcium channel blockers. Calcium channel blockers are an antagonist. they fight for that receptor, that calcium channel in the heart. So if they're going to fill that and prevent calcium from going there. This will widen our vessels, relax the heart, and again, make it less reactive. Some examples of these medications are our Ipine and like Procardia. They do not all follow this rule. Cardizem is a very popular one, especially with atrial fibrillation, and it's dilatazam. And as I said, these are also used as antiarrhythmics. SVT and AFib, it allows for rate control, and it can also allow for a pharmacologic conversion. In a person with a history of AFib, you might see this medication on their MAR, just to prevent conversion back to that irregular rhythm, to maintain the regular sinus rhythm. And one important consideration with this is not to give with grapefruit juice. Thank you, Tracy Kelly. As we continue with medication, diuretics, an important thought with diuretics is to ask yourself if this medication is wasting or sparing. We know with diuretics, you're going to deplete your fluids, and with your fluids go electrolytes. So we want to know, is this saving or is it wasting? Loop diuretics, and I've started here, I've organized them from the most drastic to the least drastic. So loop diuretics are our most impactful diuretic that we have. These work in the loop of Henle, and these are wasting diuretics. Your sodium, your potassium levels are going to deplete those. Hypokalemia, lowered potassium, typically less than 3.5, but it varies by institution. And an example of this medication is furosemide or Lasix. Our thiazide diuretics, they inhibit the sodium potassium, or the sodium chloride pumps in the kidneys in the distal end of the tubules, and these increase sodium waste. Again, another wasting diuretic. Consider hypokalemia once again. Hydrochlorothiazide and chlorothiazide are examples of those. And then oppositely, we have the potassium-sparing diuretics. Spironolactone or aldactone is an example of this. This is an aldosterone antagonist. It promotes sodium and fluid retention. For this, you should consider the opposite end of the spectrum. You should consider hyperkalemia or elevated levels of potassium, typically greater than 5.0. Elevated levels of potassium can lead to dysrhythmias, and for some patients, those can become life-threatening. Nursing care for the heart disease patient. One nursing diagnosis for a patient with heart disease is fluid volume excess. These patients are retaining fluid, and that's increasing their cardiac workload. For many of these patients, you're going to see a cardiac medication and a diuretic given simultaneously. The diuretic will take off the excess fluid that's surrounding the heart and making it work harder in that manner, whereas the cardiac medication will reduce reactivity, or it will increase given a certain medication. You should also consider limiting sodium intake. Sodium will encourage fluid retention, so it should be limited. You should consider electrolyte depletion and regularly monitor labs. And I've listed the parameter for hypokalemia and hyponatremia, which is decreased sodium here. Hyperkalemia, when using the potassium-sparing diuretic, you are going to see the peak T wave usually on the telemetry. It's the last waveform in the wave process there. It's usually peaked, not always, but that can be a sign. And in that case, you could get a 1280 kg, you could consult a physician, look at labs, some other things to verify that. And then labs greater than 5.0. For my peer review article, I have a journal entry by Dr. Kwabi of the International Journal of Nephrology from 2015. It says, underfilling due to low cardiac output or peripheral vasodilation leads to activation of sympathetic nervous system and nosocomic arginine vasopressin release. Consequently, diminished water and sodium delivery at the collecting duct of sites, in addition to renal adrenergic activity, induces renin-angiotensin-aldosterone system, which enhances tubular reabsorption. So this is talking about the way that this fluid is getting reabsorbed, and what we can do to suppress that. And now we talk about strokes. The CVA, or a stroke, 80% of strokes are preventable. With each minute that passes, you lose approximately 2 million brain cells. So what we want to do here is we want to act fast. We want to look for facial drooping. You could look for the arms slumping or weakness to one side, slurred speech, and you want to act quickly to limit that, because in less than 10 minutes you can incur serious brain damage. Another incident that you might see is a transient ischemic attack. That is less severe. That is a temporary occlusion. So for our strokes, we have hemorrhagic strokes, which account for approximately 13% of cases. This is where a ruptured vessel bleeds onto the brain. And with that, we have the subarachnoid hemorrhage. That is the spidery-looking layer that surrounds your brain. And that is a bleeding between that layer and the brain itself. And an intercerebral hemorrhage is a bleed within the brain. They are life-threatening and should be treated with urgency, because all of the time that the oxygen is being deprived, tissue is dying. And this happens in the brain because the vessels are weaker and they're more susceptible to blow out. Ischemic strokes, 87% of strokes. That's insane. Obstruction in a vessel, and this is where they become modifiable. An embolus lodges and obstructs oxygen, oxygen-rich blood from reaching that tissue. They can happen around the heart, and then they can travel to the brain and dislodge, and they really don't cause damage until they reach those smaller vessels. So why are they preventable? Because of the risk factors that can be modified to prevent these thrombus or embolus from forming in the first place. If you're obese, you can lose weight. If you smoke, you can stop. If you have high blood pressure, you can comply with your medication treatment. You can take your prophylactic anticoagulants as ordered, and stay away from vitamin K if you have AFib, things like that. So nursing care for the stroke patient, dysphagia or difficulty swallowing. You could get a swallow study to determine what their abilities are there. Occupational therapy to help them adapt to life after the stroke. Speech therapy to help them get that expressive aphasia managed. And you can consider the emotional distress of the patient. So thank you for listening.